your neighbors are there, so that we know everyone is here. Are they? They're missing here. Missing? So we'll wait for 5 minutes and then we'll have a longer siesta. You can join us. This lecture now, I will cover detoxification part in alcohol dependence. Okay? This is actually the bread and butter. Isn't it? How many of you, those who are not, forget this, other mental health professionals, but many of you or most of you have seen alcohol dependence in withdrawal, right? How many of you? So most of you know detoxification, isn't it? So this will be a revision lecture, and question answer. Okay. So just to brief you on the epidemiology. Alcohol withdrawal does take place in 70% of 70% of alcohol dependence patients do undergo withdrawal sometimes, and the rate is increased in the elderly. Though there are no gender and ethnic differences, and 85% are mild to moderate, easy to treat, they get better, and you also feel better that you have treated the symptoms and the patient is satisfied. It's only those 15% who have severe and complicated withdrawal, which we will see later on. Also, you are aware of this, that the first criterion that is essential is that cessation or reduction in the amount. So if somebody stops for some reason, it could be because somebody fell ill, it could be because the patient has been given an ultimatum by the employer, or it could be because the patient wants to quit. So in some patients, it is even voluntary that he comes to quit and decides that he is going to stay away from it. So 2 or more of the following as per the DSM-4 criteria, that is autonomic hyperactivity, tremors, insomnia, nausea, vomiting, transient hallucinations, which could be in any sensory modality, psychomotor agitation, restlessness, the patient is not able to sit at one place and is very vigilant, increased anxiety, and seizures. Any of 2 or more of these are required for the diagnosis of alcohol withdrawal. And of course, the symptoms are not due to general medical condition, and it causes a lot of socio-occupational impairment. So for alcohol withdrawal to be there is alcohol dependence, isn't it? Unless that is there, we won't see withdrawal symptoms. And there is an abstinence for some reason. As I was saying, it could be voluntary or it could be enforced by something. Not only injury and illness, but it could also be some other reasons. The wife has left him and so now he has to quit and show. The employer has said you can't come to work unless you get a certificate. So any of these reasons can lead to abstinence and we see withdrawal symptoms. To make a diagnosis, we need to take a good history, and Dr. Rao has told us in elaborate details how we do the assessment. So that will be our history. Physical examination is not only to see the liver damage, but there could be many other things in an alcoholic. For example, the patient has had many falls, so there may be signs of injury, or there may be impaired nutrition and that leading to reduced immunity and that causing many infections and diseases like tuberculosis or any other infection. So all this will be seen only by doing physical examination, otherwise it will be missed, right? I don't know if other colleges, but we have a pro forma in which we have physical examination and mental status examination as a part of de-addiction pro forma. So unless the physical examination is done, you won't see the alcoholic complications also. For example, simple things like pellagra, which is a skin ailment, and if you don't do the physical examination, you won't notice it. And of course the laboratory values, whatever is possible. Liver function tests are possible. Everywhere alcohol level is not possible. These are the predictors of severity. So older the age, the severity of alcohol withdrawal will be bigger. Then how much the person was drinking, that will also decide the severity. And prior alcohol withdrawals. Why is it important and what is that word in the brackets say? Suggest? If the patient has had prior alcohol withdrawals, what does it do to the next withdrawal?
The second withdrawal will be more vague than the previous one.
So what is kindling in short? Kindling means physiology. Yes? Yes.
Normal neurons also start to fire after
Yes.
abnormal neurons act on them.
Yes. And there is a summation that takes place. So whatever little CNS excitation had taken place in the first one, which was small enough, the next time there is more, the third time there is more, and there is a summation of all these sub-threshold stimuli. That also is responsible for seizures. Because initially in the alcohol withdrawal, you don't see seizures. But as he has undergone many alcohol withdrawal syndromes, the one time comes when that kindling has reached the threshold and that leads to seizures. So that would be important. And of course any other medicines or sedatives and hypnotics if the patient is abusing, then that will complicate that withdrawal. If the person has been having only some amount of alcohol but a lot of benzodiazepines, then the actual seizures which wouldn't have come because of alcohol may come because of benzodiazepines. So these are some of the predictors for severity. And why is it important for us to know? Because we need to know how to treat, what to expect. So we cannot, if these risk factors are there, we would rather admit the patient than treat him on outdoor basis. These are some certain tests. Again, each is not possible for us, but good to know. You have certain things which are must know, nice to know, desirable to know. So this is one of them. In the questions on a long case which are really cracking, you can be asked these questions. Okay. So blood alcohol levels can be done. Gamma glutamyl transferase, that is GGT. Then CDT, MCV, and CDT GGT is a best diagnostic combination. Dr. Rao has already spoken about this, so I won't go into the details, but this CIWA is what will tell us the severity of alcohol withdrawal. So the score of 8 to 10 would mean mild and 10 to 15 moderate and so on and so forth. The assessment has to be done till the score reaches less than 8 to 10. Now what I was saying, that why we need to know the severity of withdrawal, because we will decide the treatment setting, whether the patient will be treated in OPD or indoor. So that's why this will decide, which is the case in 80% of the patients, that we can treat them on OPD basis. So all your patients of alcohol withdrawal don't have to be admitted, unless you are in private and you want to admit your patient and give him an indoor treatment and all the tender loving care that you would like to give. But otherwise 80% of them can be treated on OPD basis. So mild to moderate dependence, then there is no history of seizures or delirium ever, or there are no other infections or medical problems, no other serious drug problems. If there is a polysubstance use, then obviously there is a problem. But otherwise, if it's just plain alcohol withdrawal, then he need not be admitted. and good social support and supervision available. That's why I don't know again about other settings, but our de-addiction center, we insist that a relative comes along with the patient even for the first time. Most of the time it's possible. Only sometimes it is a homeless or staying alone or something like that. But otherwise most of them come with a relative, and then we explain it to the relatives on day one what is their role, so that there is social support and supervision available, and in that case they can be treated on OPD basis. All the other 10 to 20% who may have severe withdrawal states like delirium tremens or seizures, he has multiple drug use, past history of many alcohol withdrawals which we discussed earlier, which leads to kindling and the severe alcohol withdrawal later, or any medical or surgical problem. The patient may come, you can see that he has jaundice or he has ascites, or there may be some other problem like poor social support, or he may not be supervised at home. Then in that case, or the distance prevents him from following up in the OPD, then in such cases, of course, the patient has to be treated indoors. And if you have tried treating him on OPD basis, so it's always better that you've given him a chance on OPD basis and that has failed. In that case, one can admit the patient. Academic and research is to complete the list. You have some project going on and you need an indoor patient for it, then you would admit. The main goal of treating alcohol withdrawal syndrome would be, one, to help the patient achieve detox in a safe and comfortable way, because many people are worried, if I stop, what will happen to me? I cannot manage. So that part has to be made safe and comfortable. That is the goal. And second is to foster the patient's motivation to enter rehabilitation. That is our other goal while we are treating the alcohol withdrawal. So course, this again all of you are aware, you see it in your patients. In the first 48 hours, the peak severity is seen. 90% of seizures also come during this time, but most cases are self-limited. Stage 2, that is 48 to 72 hours, you get the same symptoms in increased severity. Then beyond the third day, if it continues, it is not treated, then delirium tremens can set in. We will see what is delirium tremens in a few minutes. If it continues beyond 7 days, a certain like insomnia continues, whatever the symptoms are, they are self-limiting, but insomnia only continues, or some tremors continue, then that is called protracted withdrawal, which is persisting beyond 7 days. So there would be